Welcome,
Hello.
welcome. Good to see everyone. So excited about today. How are y'all?
I'm good. How's life? I
Everything's
heard Alec right before we came on live. He had a drink, an iced green tea matcha, and he spilled it on his shirt and had to change
yeah.
for
Yeah,
this
that was
very
definitely
occasion.
Alec and not you, Chris.
Yeah,
It's definitely Alec.
I think Chris is fibbing because we don't even have that in St. Louis. So we can prove you wrong right there.
They don't even have matcha.
They're behind about a year from
No,
what
we have a lot of macho. We have a lot of macho, but
yeah, a lot of matcha. Well, maybe if you open like a coffee bar that sells matcha, you'll be ahead of the times, Alec. You'll get to capitalize on all that.
If this whole OCD thing doesn't work out for you, Alec, you have a backup.
Well, I've always my singing career was always my backup, but I think this sounds even better.
Mm-hmm. Your singing career. I feel like I need to hear a lot more about that.
No, you don't.
You haven't heard about him at karaoke at the conferences?
I haven't.
Oh, no, I never go to the karaoke stuff. And you really don't want to hear more about my singing. Really don't.
I do, quite literally. But anyway, let's jump in. So excited for today. As always, you guys, this is a live stream intended to be educational, supportive, but not to replace therapy. If you're feeling unsafe or suicidal, please call 911, go to your local emergency room, and remember that IOCDF is not a crisis hotline. But we certainly are here to help provide support, education, and our goal for today is that we're able to give lots of new insight into how to best support individuals, family members, loved ones, you name it, with OCD. And we are so excited about our guest, Dr. Alec Pollard, who is an incredible clinician, researcher, and just overall advocate, an individual who's been in the field doing this work for so long. And we're really excited to talk a lot about a lot of things, but specifically about your new book, and to hear a lot about both your new book, but also maybe gain some inside insights into what's in that book and what our community needs to hear and learn.
Oh,
so thank you so much for joining us.
Well, first of all, thank you for having me. It's a delight. You two are a great combination in interviewing. So I'm excited to be part of this. And thank you for promoting the book. I just want to be clear. No kickbacks were given to Liz or Chris, your group. No. Oh, such drama.
Love the drama. Okay, so Alec, tell us a little bit. I would love to hear, first of all, a little bit about just like, I want to go back to why you even entered the OCD field and why you do this work and why you like it, or maybe you hate it. I don't know. I want to hear that.
Maybe I hate it.
Like, drop the truth bomb right now, Liz.
Tell us the truth, how you really feel.
I've never wanted to do this.
I'm a masochist. I've hated it all these years, but I just love punishing myself. So my dissertation was on chronic pain, and at the end of the dissertation, I put all this work into it. I realized I don't like working with chronic pain. What am I going to do? So what do I really like to work with? And at the time, the few cases of anxiety and OCD that I'd worked with, I thought, well, I really like working with that. Where can I get some advanced training? So I was looking at postdocs, different areas of the country, and I came across this quaint little place called the Behavior Therapy Unit at Temple University Health Sciences Center, and you know, they had like cool people, and I'm not just saying it because some of them might hear this. They're really cool. So they had, of course, Edna Foa. We all know Edna, but also on the faculty was Gail Steckity, John Grayson, Charlie Mansueto. It was an incredible group of people there, but none of them were the big stars. The big star was Joseph Wolpe, the father of behavior therapy, and he was the director of the clinic. And so, so somehow, I have no idea, without any publications, any real solid training in OCD and anxiety, I convinced them to give me a fellowship. I'm not sure to this day how that happened, but but somehow they took a chance on me. And so I went to Philly and spent a year there, absorbed in OCD and anxiety and behavioral treatments, and got supervision from top-notch people, and who were, if they're listening, way older than I was at the time. I just want to be clear. They were way, way older.
Like how much older?
Oh, God, years, centuries, some of them.
Decades, centuries. Yeah, centuries old.
Grayson was already in his 80s.
Oh, okay.
Oh, yeah. Oh, yeah. No, it's terrible. But so, at any rate, that changed my life. And I think we've all had those moments where, now, if people have lived experience, and we have a couple of people in this group that have, you can see why a person would gravitate to do that. Those without lived experience, though, usually have some moment, like some patient or some training that kind of clicks for them, and they go, wow, this is what I want to do. And that's what happened to me. I was there a week and I was already hooked. And so that, coming out of there, I had some credentials. So St. Louis University hired me to open up an OCD and anxiety clinic there at the medical center. And that's where I've been most of the time. There was I'm still affiliated with them. I'm emeritus at this point, but we broke off in 1995 and formed the Institute, but we're still affiliated with the university. So that's, and been here ever since. Never wanted to leave. We have a good thing here. We have a great crew. Everybody gets along, and it's just a great collaborative experience, and great colleagues here. So I'm still happy. And as the founding director, I want to be clear, I'm not the director. I'm the founding director. And you might be wondering, some of you out there, what does a founding director do? It's very complicated, and we don't have time to go into that because we wouldn't be able to go over the book or any other stuff, but it's very complicated. It's about 500-page textbook.
Yeah.
On founding directors. It includes things like bothering the support staff so they can't work, and being at groundbreakings of new buildings. We haven't had any yet, but just in case, I'm on call.
Yeah. You're available to help cut that ribbon. That's
yeah. So it's a tough job. And thank God we have Allison Minotti, who is the real director, who took that position 2 years ago, and she is terrific. If you haven't met her, I got to introduce you guys because she's great.
I haven't met her, so I want to be introduced for sure. That's awesome.
I saw her speak. She spoke at the conference with you one year. She was much better than you and articulate. I was like,
absolutely.
Finally somebody. No, I'm just kidding.
Yeah,
no, she was amazing. Yeah.
And don't believe anybody who says it was peaceful transition of power. He came in with an army in the midnight. They took over my office. It was ugly, but I've forgiven her.
I want to say real quick, I'm glad Liz asked that question about like kind of what got you into it, because I know obviously Liz and I got into it because of our own experience, but I'm always fascinated. I am really close with Barbara Vanopin, and she has a similar story. She was kind of just working with different clients, worked with a couple people with OCD, and was fascinated. So I always tell people like, thank you, because of all the work that you all have done. We don't have enough researchers and clinicians as it is, but it's just great that people for some reason gravitated towards this work, because we need all the hands on deck we can get.
Agreed. And if you see Barbara, could you tell her, since you've been fibbing already today, this won't be a stretch for you, Chris, to tell her that I said the reason I got in the field was because of Barbara. Okay, I'll
tell her that.
Thank you.
Tell us a little bit about what you started to see. Like, you got into this role and you started working with clients. I'm always curious because in my thesis in grad school, one of the things I did was kind of look at what OCD treatment looked like over the decades. And it was not as hopeful as it is now. I mean, I think, you know, one of the things that I think Liz is really leading the charge on is like giving people hope. But I mean, I was looking at the stuff in the 80s, the 90s for, you know, for my thesis, and even the early 2000s. And a lot of it was kind of doom and gloom, not a lot of like real stories of people getting better. So how did you kind of see it at the start, and what have you seen it look like much more recently?
Well, one of the things, just kind of in going with that themes, one of the things I've noticed in doing the trainings is how many more people with lived experience are going into the field, like the two of you have. And I'm sure that some of them have been inspired by one or both of you. You know, there was a time when there was great trepidation. I'm talking about years ago, about someone with lived experience becoming a therapist. You know, because you've always had some people who, let's just say they went into the field before they had really experienced treatment, and it wasn't pretty. But so many people have gone now because of the access to treatment that is so much better, no matter how much we need to still do. It's so much better than when I started out, because if you met somebody with lived experience who was a therapist, it means they haven't been treated back then, because there was not enough centers. I mean, you could have on one hand the number of centers nationally that were out there. Ours was the first in the Midwest, anywhere. I'm from, well, I can't even tell you from what city to what city, but so now, because of the improved access, more people can get care, good care, and they are getting the right care. And that, I think, is inspiring them. You guys could speak to that more than me. I think that inspires them to say, hey, I want to do this for other people. And it's such a powerful movement, and really great to see. We have a couple of people on our staff that have lived experience, and you know, some of our best top-notch therapists. So it's great.
I love that. I love hearing that. And it is, I will say, I was just talking this morning to a couple individuals really involved in IOCDF, just about how great it is to see the change in what's happened over the last 15 years of people not just willing to speak about OCD, but now entering the field. And we know that, like, most of us that are clinicians, whether you have OCD or not, you entered this field for a reason. Like, there's something that drove you to want to help people. You didn't enter for the money. I know that's shocking, but none of us are getting rich off of being an OCD clinician. No. You know? And so you entered because of some sort of passion and desire. And so it's nice to be at a place where people can talk more openly about that, you know, and not feel like they have to hide or dismiss that. And I remember even just the difference of from when I was in grad school till now, it's so different.
Oh, absolutely. When in my day, I mean, when I would have been looking for jobs, if I had had OCD, I probably wouldn't have said anything to anybody about it. And now people, like, they're right up front about it. I'm sure not everybody, but most people, they come in, we interview them for a job. If they're lived experience, they say it.
Yeah, exactly. Especially if it's well managed. So let's talk a little bit about Alec. I know you've done obviously some incredible work with intensive OCD treatment for patients, and you know the difference that you've been able to make in individuals' lives. But I also feel like part of your legacy in the OCD world has been the impact you've had on family members and treating the whole family system, helping family members get patients to treatment, and helping patients get motivated to be willing to do treatment. You know, here at our program, we use a ton of your stuff, whether it's treatment interfering behaviors and talking about TIBs all the time, or talking about readiness and like how we help patients get ready for treatment, right? And what that looks like. Some of our most severe patients actually aren't ready for residential care. They need to spend time getting ready for the treatment to be successful. So why don't we start with readiness? Because I think that's just such an important topic. Is tell us a little bit about what you found just over the years with your work with patients of why is readiness so important, and what does that even look like to help a patient get ready for treatment?
That's a great question. Yeah, and I've said this many times cognitive behavior therapists, we have much to be proud of. If it wasn't for us, everybody with OCD would only be getting medication because the pharmaceutical companies were sort of promoting these medicines as the breakthrough. And then when they would do it, like, and I'm talking now in the 80s and early 90s. So then they would do something on advances in OCD treatment. They would lose face if they didn't have cognitive behavior therapist on talking about that, and got a lot of criticism when they tried to have just a panel on medicine. And so my point here is simply that I am a CBTer. I'll probably always will be, but I also see our limitations, the things that we haven't done, and that's and what we were not good at early on, at least, was looking at our failures. And I want to put that in quotes, because when I say our failures, I mean our failures. I don't mean the patient's failures, because it's our job to figure out, just because somebody has extra problems that's keeping them from engaging in treatment, that's not their fault. That's our responsibility to figure out how to help them. That's our job. So always I've come at it from the idea of what can we do as clinicians more to try to help folks who maybe through no fault of their own, and unfortunately have more than one obstacle. They have OCD, but then they may have other obstacles that get in the way. So that's kind of always been, my way of thinking about it. And so, gosh, I don't know when it was exactly, probably late 80s, early 90s. I started looking at TIBS and reading about what little was out there on it. And gradually, I want to say that that cognitive behavior therapists, many of them, came along and started looking at interventions to address something along the lines of treatment engagement or readiness or, motivational interviewing. Now, that's actually not what most people think of as a cognitive behavioral strategy, but Miller was a behaviorist, and he was looking for something that to deal a different way to approach substance use, and and it's more gestalty, for lack of a better word. I don't know if that's a word, gestalty, but not generally considered a behavioral approach. And then people in the cognitive field have started looking at cognitive interventions for to address readiness or obstacles to treatment that were cognitive and based. Marshall Linehan and dialectical behavior therapy, treatment interfering behavior, or she would call it therapy interfering behavior. But I've expanded the term to treatment interfering behavior because I feel like these are phenomena that need to be studied across all clinicians, not just psychotherapists. But patients show up late for their physician's appointments as well, or they don't do their physical therapy homework. It's not restricted to psychotherapy. So treatment interfering behavior to me is the broader term that really incorporates this array of behaviors that keep people from working effectively. So as I always do, I just start talking about it with my colleagues, and I feed off of them. We start brainstorming together about, well, what could we do? And then we start reading and whatever is out there, and then we start putting things together that might be helpful. And then eventually kind of, because I tend to move beyond any single school of CBT. I want to steal from everybody. And I can say this today proudly that I've never had an original idea in my entire life. I just steal from the smartest people, and you just got to know who to steal from. And I try to give them credit. Don't get me wrong. I don't present it as my stuff unless it is. So maybe what's unique about both the treatment interfering behavior work that I've done and also the family work is the how we combine them together and create a treatment package and so when I would sit in our staff meetings, I'd say, just think out loud, forget your theories or whatever, or your school of thought. Who had a patient this week that didn't do their homework or whatever? And somebody says, so I'd ask them, why do you think they didn't do their homework? What do you think? And then we'd go around the room. Well, I think it was this. I think it was that. And you could tell that people were influenced by the theories they knew. But what people hadn't done hadn't done at the time was take the theories they already knew and apply them to treatment interfering behavior instead of OCD or social anxiety or whatever. So in other words, there are belief systems, if you're a cognitive therapist, that are treatment incompatible. If I believe that I can't get better, or I had one guy who believed that, and this was, you could certainly see how that was OCD-ish. He believed that if he took advice from anyone besides himself, it would contaminate the purity of who he was. Mm-hmm. Now, you can definitely see how that was going to interfere with therapy. So then why else? Well, he's not very good with time and time management and organizational skill. Yeah, that's another reason. Oh, look, behavior therapists have time management skills training and things like that in their repertoire. Okay, why aren't we applying it to this? And then looking at the role of motivation and the work that's being done in that, and values clarification that came later, and then also rewards and punishments, more immediate contingencies that shape behavior. So if I go home and my evil therapist is giving me an anxiety-provoking exposure homework, and I see my video game over there talking to me, compelling me to come over and play, and my dilemma is now, oh, okay, I can do my therapist assignment, which really is uncomfortable. And when is it uncomfortable? Immediately. And or I can go immediately get some stimulation by playing video games. Oh, guess which one wins? So looking at both the immediate contingencies, long-term, do we have goals? Do we have motivation just to engage in it? What skill deficits, including emotion regulation kinds of skills, and or cognitions, belief systems, might contribute to behavior that's incompatible with engagement and treatment. So that's kind of how I just sort of put together all these different strategies. But the thing that was the most challenging was because I came to the determination that some patients need to stop treating their OCD, or by the way, everything we say about OCD, we could be saying about social anxiety or depression. I'm just saying about OCD because that's our focus today. But I came to the determination that you're actually doing more harm, sometimes continuing to treat somebody unsuccessfully, even though you're using an evidence-based treatment. Because how many times have we heard patients say, I tried CBT, but it didn't work? Okay. Well, a lot of times through no fault of their own, they didn't try it. They think they did, but they didn't. And the reason they didn't try it is because of their TIBs. And the reason it didn't get resolved is because the therapist didn't address the TIBs. Now, I can't guarantee a patient will agree to work on TIBs. But what I can guarantee is they won't leave my office thinking that they did CBT. And it's not the way that
Can we talk about that a little bit more? I think this is such an important topic, you guys, because this is one of the things I'm hearing so much right now, Alec, right? So many folks saying like ERP doesn't work for me, or ERP is not useful, or CBT wasn't helpful for my anxiety. And we did a talk, webinar with John Abramowitz a while ago. And I told John in the talk, I said, John, listen, I would have been one of those people that would have said ERP doesn't work for me for 10 to 15 years because I wasn't actually doing ERP, right? I was 1 foot in, 1 foot out. I was doing what I wanted, but holding on here. But I actually had a great clinician who was able to tell me, like, you're not really doing ERP and we need to make sure you know that, right? And so I knew that I was the one holding myself back and did not leave with this misunderstanding that, oh, ERP is the problem. Not to say that I want patients to leave saying they're the problem, but we do need to be able to at least be able to understand and acknowledge, okay, the reason I'm only getting so far is because of these reasons versus, oh, ERP can only get me so far.
Yeah.
So I would love for you to talk a little bit about how both as clinicians and for patients, but really as clinicians, how important is it that we're having this conversation with patients and that we are making sure two things are happening? That number one, we're not treating a patient who we shouldn't be treating because we're not helping them. And also, how do we make sure patients have an understanding if they're not getting better, that we're talking to them about why and what's going on, and how maybe you can even talk a little bit about how maybe anxiety provoking that is for clinicians to do and why that's hard for them.
It's really hard. Yeah. And just a side note, Liz, you made me think about an interesting study, which would be to interview people like yourself who were treatment resistant for a while, and then something clicked for them, something changed. It would be fascinating to identify people who that is their story and interview what do you see from your perspective as the thing that made the switch, the click? And you identified your therapist as helping for sure. But what was it about that, what that therapist did? I'm not asking you to reveal that now, but I'm just saying it would be a really interesting survey of folks who have been through.
No, and I can reveal it. I've talked about it because it's not groundbreaking, right? I think so many people want me to say, oh, someone said this to me, or this thing happened and it was just this aha moment. But actually, honestly, for 15 years of my life, right? Going to high school, going to college, going to grad school, doing internship, previous relationships that weren't great, all of these things, I could have both. I was able to function with OCD and still achieve these other things.
Right.
And actually the difference for me was when I made the conscious choice and I started to say, I don't want to have both. Like, I want more for my life and my OCD is holding me back. And that's a choice that I'm making, right? When I was able to recognize I was choosing that instead of being in this mentality of, oh, this is so terrible, I have to suffer forever, like this is something I can't control. I had to kind of say, I'm the only one that can take ownership of making this change. Because the reality is that if you've had good ERP treatment, even if you didn't do ERP, you know what you need to do.
Yeah.
Right? Like, I knew what I needed to do. I just didn't want to do it because it was like, well, I don't have to. And I can still go to school. I can still make good grades. I could do both. And so I think that's just, but it's so important for us to be able to, I never was at a place where I was like, oh, ERP won't work. I knew that ERP probably would work. I just wasn't willing to do it.
Yeah, no, that's a good point. Chris, did you have?
Yeah, I mean, two thoughts came up while you guys were talking. I mean, one of the things that was kind of groundbreaking, I don't know if Liz remembers this, but my mom, my sister, and I did a talk with Liz. I think it was for the IOCDF online conference. And we were going through kind of the stages, and I had a lot of anger in my teen years. My dad stopped, I wasn't living with my dad anymore. The OCD got really bad. The BDD got really bad. I was, abusing alcohol to kind of, deal with the intrusive thoughts. I wasn't in a good place, and I was angry, and I would like slam doors and break things and, kind of use, my anger to intimidate everybody I lived with to do what they were doing. And I remember Liz saying, like, at that moment, Chris would not, because there's been a little bit of like sadness in the family. Like, we wish we would have gotten Chris in treatment earlier, but it was kind of an aha moment when Liz said, I don't think Chris would have done well in ERP at that point in his life. He needed DBT. He needed to work on the anger. He needed to work on family dynamics. And so it kind of had me reframe my treatment. I was ready for treatment because I had hit rock bottom. I had a suicide attempt. I was hospitalized. I spent 2 years. Why I'm so advocating for ERP and evidence-based treatments, despite criticisms from people, is because I spent 2 years after being in a hospital getting talk therapy, tapping, snap a rubber band, visualize a beach. And I'm like, that's not helpful, right? So the second reason I was successful in treatment and why she gets all the credit is my mom. You know, she was fearless and she's like, we're going to find you treatment, found the IOCDF, why I'm always forever grateful to this organization, got me evidence-based care. But I think what you guys are both talking about, and it was just like an aha moment in that talk, is like, you know, we know the treatment works. We just have to make sure everybody's on board. And I don't think my teenage years I would have been on board. I was too angry. I was much more dysregulated, and I would have needed that first. By the time I got into therapy, I was so beaten down that I was like, please just do something to get these thoughts to stop. And that's when I was ready to receive it. But I wasn't ready until I think I was 23 when I started treatment, or 22. I would not have been ready prior to that. And it wouldn't have been the treatment or the clinician's fault.
Well, you both are making tremendous points. And it's so helpful to hear your own experiences, I'm sure, for a lot of folks out there. But to pick up on something you said, Chris, about you weren't ready, and it kind of also resonates with Liz, what you wanted me to talk about was this idea that because therapists need to be really tuned in to whether patients are ready or not. And sometimes they make the mistake of going ahead and treating them with ERP when they're not ready. And so what we need in our field is to get therapists more comfortable with not treating, not using the thing that they are anxious to use. And understandably, you know, it's very powerful if you've got the right person at the right time and ready to go. So we have to get more comfortable with trusting that we are not the all-powerful beings in this patient's life. And sometimes the patient may have to go back out into the world and experience more things that life can teach people and give them motivation and all sorts of things much more powerfully than I am. I mean, the best I can do is offer an M&M if they show up for the session, and that's not really.
Sometimes it works. I'm potty training my 2-year-old, and the M&Ms are very powerful, Alec.
Here's my secret. I have mints in my office because for some reason I could never find the right candy that people liked. And one day I bought mints, and it was for myself, and a client asked for it, and then he kept asking. And then, speaking of Barbara Vanop, her husband makes beautiful glass, like different vases and stuff. And he made me a candy dish. Now mints, people eat those things up, and they're only $3 at CVS. It's great.
Okay, good to know. We've learned something, audience. If you have a 2-year-old patient, use M&Ms.
That's right.
And if it's an adult, mints. Okay, I don't know. We need more research on this, but I do want to. It's funny when we do the BTTIs, and I spend Friday like going over, you know, ERP, what's an obsession, compulsion, blah, 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 all day. And then we come back Saturday and they learn how to adapt it to children, and they learn about medication. And then at the end of Saturday, I introduce them to the idea of TIBS, and it always feels like a rotten trick. We've told you how great this thing is for 2 days, and now I'm telling you when not to use it. But it has to be said because, and sometimes you'll know right away, this is just not going to work. And I will say probably the thing that I've learned the most in my career, how am I different than when I first started out? I'm much less patient. I'm not willing to waste time like I used to. So I'm bolder in saying, nope, I'm not going to do that. Or the fastest assessment of readiness I've ever made. And I haven't contacted the Guinness Book of World Records, but I went out into the waiting area, and by the way, this was in a physical waiting area. For those of you who are younger therapists, patients used to actually come into the building. They would drive a car or take a bus. Oh, never mind. Anyway, so I went out into the physical waiting room, and this patient had 2 clear disorders. I knew about the OCD, but I didn't also know about chronic adolescent disorder that he had. He was also an adolescent. So there were 2 disorders I had to deal with. So I went out in the waiting area and I said, Johnny, do you want to join me in the office? He goes, no. And I go, oh, well, your parents are here. You sure? No. Okay. Mom and Dad, come on with me. And we left him out in the waiting area. Now that took me, 15 seconds. So I'm open to people beating my readiness assessment. If you can, that's great, but 15 seconds kind of hard to beat. And then I brought the parents in. Now, when I was first starting out, I would have spent all sorts of time in that waiting area trying to talk Johnny and come on, Johnny, I got mints, because I just talked to Chris and I learned a new technique. But now it's like, nope, let's go. And the parents are like, what? Aren't you going to treat our child? Well, come on, I'll explain more in the room. And that's kind of the biggest change, is sort of realizing how important it is. Now, we're not magicians. We're not soothsayers. So we don't always get it right. So we think somebody is ready, and then we do treatment. And then we discover not necessarily that they weren't ready, but they weren't ready enough, or they've got a tib that needs to be addressed. So now, how do we address that? So we all have our strategies for, they don't do their homework. Let's talk about what happened. All right, Ms. McGillicuddy, poor Ms. McGillicuddy, she's still hanging in there in treatment. But Ms. McGillicuddy, by the way, I always use her as my patient. It's become so infamous that I have people at meetings, at conferences, stopping me going, how is Miss McGillicuddy? They're concerned.
Like, I'm actually not sure because but I can make a guess and maybe right.
Yeah, and I'm touched by their concern. Well, I made that patient up. It really is a conglomerate, because no human being, as much as we're aware of comorbidity, no human being could have all of the problems I've ascribed to her over the years in their trainings. So anyway, we problem solve with our patients. We try to figure out what got in the way, and then we have an intervention. And so my motto when we have non-adherence is, we cannot leave the session. No judgment. That's cool. It's always my fault. I misjudged the assignment. Let's figure out something different. Now, occasionally I blame Chris, but they just look at me and go, who is Chris? So stop doing that. Great. So I take responsibility. But our deal is this: when you leave the office, we must exit the office with one of 2 things. We're either going to make the assignment easier, so it's more likely that you'll do it, or we're going to add an intervention to make it more likely you'll do it. Right. But we are not going to do the same thing 2 weeks in a row. And you proclaiming that you are going to do it, that's not something new, because you proclaimed that last week. And unless you were fibbing to me, and then, no, I wasn't fibbing.
But I think this is so important, and I like to talk about this a lot, is that if somebody didn't meet their homework goals, we don't just keep trying the same goals. We need to figure out, was it that they were too hard or they weren't willing to do it? And if they're not willing to do it, we need to think of another intervention. But I love, Alec, your waiting room analogy, because there are so many clinicians, and really I know a lot of y'all are patients with OCD, but the Lunch and Learn is also for clinicians, where we get, or you get pulled in, right? And you get in these debates and you find yourself, and I'll never forget one of my training, I feel like I've done a lot of training, but one of my training experiences at UPMC with Dr. Hudak's group. And when I was working up there, I remember a clinician said to me, you just can't want it more than they do, Liz. because there was a patient that I was like, but if he'll just do these few things, he'll have his life back. Like, I need to help him see that. And the reality is he didn't want to see it. And I wanted to be the one that could, right? Good intention. I wanted to be the one because I wanted him to get better. But at the end of the day, like, you have to want it more than your clinician wants it for you, right? You have to have that drive more. And I do think it's so hard for us. Two things you brought up as a clinician is to accept that, to be able to see patients where they are versus where we want them to be. And to be able to acknowledge, okay, like, this is where you're at. And so we can either do readiness work, or you should go live your life and come back when you're ready to do this treatment. And that can be hard, but sometimes the most helpful intervention.
And just to state the obvious for any clinicians out there, well, patients too, quite frankly, need to know this. What we're not going to do for any length of time is keep doing what we're doing without changing it and have it not work. That's the worst case. That's what you don't want to do. And that this gets at, I think, what you were hinting at earlier, Liz, is that so many therapists, and myself included when I first, they don't want to give up because they feel like it's failure, right? I failed with this case. And I really want to encourage people to not think that way.
Yeah.
And that you're not responsible for everything in the world. And don't take it on. Sometimes you need help, and sometimes that help comes from real life. And so you and patients, as you guys could testify, recovery is a journey. It's not a 6-week trial. It's a way of life that you take on, and you're going to have ups and downs. And that's true for the clinicians as well. You're part of their journey. You're not the whole responsibility. I've had patients that we terminated care. And by the way, I want to say that I have very rarely terminated patients. That I can count on one hand. What I do is I change the conditions under which I'm willing to see them, and they reject me sometimes. But I don't terminate them. But I leave the door open, and you always want to do that, clinicians, is to try to not have it be acrimonious, but just, hey, see what, try this, or they get some new treatment. I've primal scream therapy. I heard it's really good for OCD. By the way, for those, no, it's not. I'm just a joke, but okay, if I can't say, well, we don't have any evidence for that. Where are you getting that? But I'm not going to get in an argument with them. All right, go try it. I'm here. They might come back a year later. And so it's really important for clinicians to know that let people go on their journey. It's not your responsibility, and always leave the door open for them to come back. Yeah.
Well, it's kind of what Liz was saying too. It's like, I don't want clients to ever think it was the treatment that didn't work out. I want them to know, like, hey, we didn't, I worked with a young girl, and the parents were like very, very upfront. They're like, look, you're probably therapist number, 17, just doesn't want to do the work. And I made sure, we spent the first week together, just working on kind of like where she was at, et cetera. And she was a very lovely person. And she finally said at the end, she's like, it's not the treatment. I just don't want to change. And I was like, okay, let's not do the treatment then. And I'm here if you just want to come and like talk and just have a place to kind of check in each week. But I don't want us to move forward with treatment and you have another person the treatment failed with. And so, it's so important because like, you both were saying, it's like, we don't want people to think the treatment doesn't work. We all want to be in a right place. And now sometimes that means, there's co-occurring disorders, right? Like sometimes we have a client who has such deep depression that it's hard for them to even bathe or get to the office, let alone to start, challenging the OCD, or they're also dealing with PTSD. They're having a lot of flashbacks and they're really struggling with their well-being. So, I think, what I always think about the BTTI and stuff, and why I always tell people, it's like, as you start to work with OCD, it's so important that you start to kind of listen to these like live streams and other trainings, because there's going to be things that you encounter, and you want to make sure that you're able to help the person. We have the best intentions, but sometimes what we're going to do to help a patient might not look like how we've, helped others or how we've been trained.
Yeah, I agree. And I'd be remiss if I didn't make this point, because if I don't, some clinicians could think, well, if they're not doing well, you just let them go. And I'm not saying that's all you have to offer.
Right.
It's our job to figure out why they're not fully engaged and to offer interventions to help them address it. Now, that's what I mean about, I've never terminated somebody, but I have been able to say to them, we're not doing CBT right now.
Yeah.
And that's my fault because I haven't helped you figure out how to engage better. And I'd like to do that. And I'm offering to do that. But what I won't do is keep treating your OCD right now without us doing this first. This is when I get to the point now that it's really clear to me that their level of TIBs preclude any kind of effective treatment. When I'm really convinced, then and my stance is this: I would be because sometimes they argue with me, say, "Well, no, I want to keep working on my OCD." And say, "Well, I'm not offering you that option. You can work with someone else on your OCD, or try to, or you can work with me on your TIB. But it would be unethical for me to keep working on your OCD under conditions I know won't work. And you can't make that decision for me to do something unethical. And that's the way I see it. That once you are really convinced of what needs to happen, and you don't at least present that to the patient, then to me that would be unethical.
And I think this is, we need to pause for a second, because I do think that for those of us that are CBT trained, this is really hard, because a lot of CBT clinicians, so I hear this all the time, where when our patients first came here to our residential program, within day one, clinicians felt like they had to produce this behavior plan that then had exposures on it. Yeah. And I remember when I first got here, sitting in team meeting and being like, why do you feel like you need to create that day one? And they were like, well, because people are here and they're here for ERP, and we feel guilty, and we feel like as a CBT therapist, you're supposed to be giving homework and giving assignments and doing stuff. And I was like, yeah, we're not going to do that anymore. We now have a standard VP that we give to everyone that has videos and education and content, and that's what they're going to do first. And everybody felt so relieved, but there is this clinician pressure of CBT clinicians, you shouldn't be talking and doing readiness, you need to be doing behavioral work from the beginning. But what everyone needs to hear is that if a patient isn't ready for behavioral work, it falls flat. Absolutely. And it ends up causing so much more damage, right? I talk about this from advocacy all the time, but it makes so many people feel like treatment doesn't work for me. They exhaust resources in treatment when they weren't ready. And I have my own theory, and then there's a lot of questions I've been reading through. So many people have great comments, so we'll kind of hop to those too. But I have this theory, and Chris and Alec, I'm curious if y'all see this in your own clinical work as well. But I talk a lot about how I want us to be fighting for freedom, not functioning. And that so many people with OCD use ERP to be able to function. So we do enough ERP to be able to function, and then we're back in life and we're functioning, but we still have OCD. We're still ritualizing, we're still holding on. But we're, it's smaller, sure, or we've gotten a little bit of relief. And I think people sometimes hear the statement I'll make of freedom over functioning, of you only have to fight for freedom. And so instead, what I've started to see on my own and believe is that it's kind of like this stepwise process, where I feel like when you're ready for ERP, treatment first gets you to function. And then I actually want you to go back into the world and to function. And as you start functioning and you start having a new life and a bigger life and doing things you previously couldn't do, then you're ready to take that next step to really push all the way and get to freedom, because you've got this motivation, you've got these values, where otherwise I feel like sometimes we're trying to convince someone of a value that they don't feel is tangible, because that's so far from what they've had for so long. So I don't know if y'all see that, but I see this ERP gets you to get back into life. Then I want you to go integrate with life, and then you're going to be willing to do the next pieces. Yeah,
I've never thought of it with those particular terms, but absolutely. And that's another choice point, isn't it? Where the patient has to decide, do I want to take it to the next, I would think of it as the next level, but I like the freedom metaphor. And so, yeah, that's absolutely, one of the issues. And you probably have seen folks who get just enough better that they're getting some of the stuff, the goodies from life that they had missed by being disabled. But and so that they're mostly satisfied, not totally, but mostly. And that actually is another point at which you may see disengagement, right? Because, all right, I'm not as motivated because I'm not suffering as much on a daily basis. And I think some of those folks are maybe using your model, Liz, are on the precipice of freedom. They're not ready yet for freedom, but they're sort of in that zone where they could move towards it or not. Yeah.
Yeah, I know for me, I mean, once I got back into life, that's really where the motivation came. You know, I went back and I volunteered at an animal shelter despite having like fears of animal-borne illnesses, right? But like showing up to animal shelter, feeling committed, that's one of the conversations that we had at the conference, Liz, Michelle, and myself, Michelle Massey, about learned helplessness. And one of the things that happens is people stop getting that feeling of like accomplishment. And I remember like going to the animal shelter and they like promoted me and let me walk the dogs, which, you know, I love dogs and everything, but all these accomplishments I started making was really motivating. I had a client that did so well in treatment. And then she was like, okay, I'm done, you know, and the parents are like, no, you can still work with Chris. And one of the real kind of game-changing experiences for her is she got, she went to cosmetology school and got a job working for like a vegan skincare brand, which was really aligned with her values. And that's when she just like ran to that recovery finish line. So I tell clients like getting back out in life, whether it's volunteering, going back to school, you know, traveling, whatever you want to do, that is part of treatment, because then you get to use your skills in real time and you finally get the payoffs instead of just like, yay, you did a good job in the office, right? Now it's like, yay, you did a good job. And we're able to present this concept at a retreat that you're really excited about. And now you're getting the accolades from the hard work. So I think it's so crucial part of treatment.
That's a great point. By the way, Chris, are you fully aware that there's a lot of yuckiness at animal welfare center? I mean, I just wanted to warn you.
You mean like the animals or like the things the place did?
Everything, yeah.
No, they were a really cool shelter. It was like a no-kill shelter. Really loved it. But yeah, I mean, it was the greatest ERP for me because I had to pick up dog poop. I had to like bathe the dogs. You know, my brain's like, you're going to get rabies. That was a big fear of mine. But I always tell people like, that's why I love real life exposures, like putting yourself back into real life. You know, I'll have clients that tell me I have a newborn baby and I'm changing diapers and my OCD is yelling, but I'm so happy to be the parent. Or somebody who, you know, I had a client that went on a trip on a sailboat and their big fear was like falling off or getting sick, or just they had all these fears. Yeah. They have all these pictures of them doing like the Titanic on top of the world. So I think it's always easier to implement what we teach them in spaces that are much more fun, like a concert. But it's such a full moment for our clients to be able to get back into those things they cherish. So I always remind clients, like, that's what you're doing this for.
Well, another angle of this, I think we're kind of all saying the same thing in different ways, but I think one of the underrecognized casualties of OCD, because we always talk about how much suffering, is the absence of joy. And it's really, really noticeable in my patients that, you know, I think about, oh, this weekend, I'm going to go to a concert. I'm going to do this. I'm going to do that. And it kind of gets me through the week because looking forward to it. But for a lot of my patients, I don't see that. You know, it's how do I get out the door, you know? And so we've become so much more able to recognize the importance of valued activity and pleasurable events. That's a huge recognition that anxious patients need, not just to reduce their anxiety, but because a lot of times the casualties have included losing these things that bring them meaning and pleasure. And I think that's kind of what we're talking about in different ways. And how important, and that was one of the lessons we learned in the family stuff that we did. We weren't focusing on that. And that's how we began to discover that, wait a minute, these family members can't do some of the things that we want them to do because emotionally they themselves are so compromised. And part of that is the loss of valued activity that they have experienced devoting their time to helping the family member with OCD.
So I have a final question as we wrap up that is just on my mind and really relevant. But what do you do when you feel like you have patients who are wanting to do ERP? Like you said, they're kind of saying they really want to do ERP, but they're just continuing to negotiate with OCD, right? They're saying like, I want to do ERP, but then they're also saying, I'm not willing to totally treat this as OCD, right? Maybe I'm struggling to not treat this as a true contamination risk or faith problem or whatever it might be. How do you approach that? And how do you help them? Because I feel like I kind of just often will say, okay, well, like you have to make that choice. You have to choose to treat it as OCD or not. Because no matter what I say, like I'm not going to be able to be the one to convince you. But I'm curious what your approach would be.
Yeah, no, that's another good question. So it speaks to a strategy that I use a lot with patients, which is this, and it's how I avoid a lot of arguments. I should use that in my own life. At any rate, we'll get back to that later.
That's another story.
That's right, a whole nother story. So, so when I identify something that I think the patient is getting wrong, or I don't agree with, which of course means they're wrong, of course. All right, so I know we could potentially get into it like, yes, you do have to do this, or no, I don't. So unless I think what they want to do is, let's say, for example, that identify that I don't think they're on board. I think that's what you were getting at, Liz, that they're really not going to lean into it. I see an obstacle, and I'll identify it. I'll say, you know, I'm a little concerned about blah, 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 but I won't not treat them, but I'm gonna identify it and plant the seed. And I say, I tell you what, can we agree now that if I'm right about this, and I hope I am, I hope I'm not, seriously, but if I'm right about that, let's agree on a certain period of time that if that's getting in the way, that you be willing to come back and reconsider what you've said today. And if you're willing to do that, I'm willing to go ahead and try it the way you want. But only if you agree a month from now that we'll reevaluate this. Are you willing? So in other words, I don't try to get them to say the right answer in that moment, because that's really hard anyway for anybody, especially OCD. But I'd lay it out there. And because, you know, many of our patients are very conscientious and good people, they won't go back on their word if they promised to reevaluate it after a month or whatever the time period is. So that's kind of how I handle it. I stay out of, like, you know, the power struggles. Just, all right, you say this, I say this, but again, I hope I'm wrong. I don't want them to be invested in proving me wrong, although sometimes that works to your advantage. But let's just, and that's that whole thing, that whole philosophy that I want my patients to have is the journey of discovery, that this is what life is about. It's about discovering what's true, not figuring it out in your head, but discovering. We don't know. Eventually we're going to have to try it. Right. And let's see what happens.
Yeah.
That's what ERP is, really.
Yeah.
Yeah.
That's what I always tell people, you know, is I think the biggest belief that's negative belief with OCD treatment is I need to feel a certain way before I do it, right? And it's like, well, then we don't understand CBT, because CBT is we have to do something different before we feel it, right? So you're not going to be able to know it was OCD until you actually are willing to take that risk and treat it as OCD and do different things behaviorally. And so, but it's hard, right? And of course, in that moment, when you feel anxious, when you have that physiological true feeling and response, it's much easier said than done, you know, for us to say, just treat it as OCD, you can do it. So
absolutely. Yeah.
Alec, I know we're at the end, but Liz and I and on the foundation, we just wanted to obviously say, like, congratulations again on your Career Achievement Award. I mean, that was so great to see you. They have a great shot that went up on the site just, you know, for all the people that you've, the clinicians watching that you've affected or impacted, or the people that have OCD that may not know that your, you know, trainings have affected us, because, you know, we know on the back end, most clinicians that they're working with are because they went through a BTTI training with you. Congratulations. Just to take us out, what was that like to stand on stage and just have everybody just really celebrate all the hard work that you've put into this field?
I hated it. I hated it and I loved it at the same time. And you probably know what I mean by that.
Yeah.
Yeah. It was so nice and so gratifying. And my son was there, and the first time he'd been to IOCDF meeting. So he got a kick. He got a kick of how quote crazy all of my colleagues are. But so it was very gratifying, but it's not my most comfortable place to be in the, you know, in that light, to be honest. I'm comfortable in front of people, obviously. I think you know that. But to have the light shining directly on me so strongly is not my most comfortable thing. But I would be failing all of my patients and be a hypocrite if I didn't say you need to do things that aren't comfortable always, so that I could get the good parts of that as well. Yeah.
Well, I will tell you that we're just so grateful for you, your work, and I know so many individuals that you've directly impacted, and of course individuals who don't even know you've impacted through your books and work are so grateful for you and honored that you chose to do this work in this field over pain management. I certainly believe it's more fun, but we're really grateful for it. I know it's interesting because so many of you guys that are, I would consider, are like legends in the field, even Mike Janicki, right? Like he kind of stumbled on OCD. His original work was going to be in Alzheimer's, and then, you know, and it's just, you end up in the place you're meant to be, and you are certainly meant to be in this arena. So thank you for all the work. The insight's amazing. And I think my takeaway for today that I hope people can hear is that ERP can be life-changing, and it really is a treatment modality that we know works, but you have to be ready for it, and you have to want it, and you have to be willing to do it. And if you're not, that's okay, but we shouldn't keep trying to do something you're not ready to do, because that isn't going to give you the benefits you deserve.
Now, one limitation I'll say of ERP is it doesn't grow hair, and I'm very upset about that.
One day, maybe that'll be the next, a tool that develops one day.
Yeah, can't do everything. Yeah,
exactly.
I just want to say quickly, you know, if you liked a lot of the topics we talked about, obviously it's in Alec's new book. If you want to learn more about the book, I'm going to do a shameless plug. My mom and I run a free family and loved ones OCD support group that Liz McIngvale has been on. But this Saturday from 11 to 1 Pacific Standard Time, we're having Alec on, and we're really going to go through chapter to chapter, talk about the concepts, and really go deep in the book. So if you have OCD, there's a lot of good information if you're a loved one with that. So just email info@ocdsocal.org. We'll send you the link, and you could come on Saturday. And I don't know if Liz remembers, but she's going to be on the family group in November, because we're going to do it live from the board meeting. So both of them will be on this year. But hopefully, if you want to learn more about the book, definitely be there this Saturday. We'd love to have you. It's a free event, virtual.
Great.
Thanks, Alec. Bye,
Thank
Chris.
you guys. Appreciate it.
Take care, everyone. Thank you for hanging out with us for an hour.